Good afternoon, and welcome to this week's episode of Ask Dr. Murphy. I hope everyone is doing well today. My name is Katie Berg. I'm a research study coordinator with the Havey Institute, and I'll be leading today's discussion. I'd like to welcome and introduce Dr. Robert Murphy. Dr. Murphy, how are you today?
I'm doing quite well.
Dr. Robert Murphy is the executive director of the Havey Institute for Global Health and the John Philip Fair Professor of Infectious Diseases here at Northwestern's Feinberg School of Medicine. He answers your COVID, infectious disease, and public health questions each week here on the Havey Institute for Global Health's Facebook page. Today, Dr. Murphy will be addressing the latest headlines and U.S. COVID statistics, as well as answering some submitted questions through today, March 1st. We invite you to submit questions down below via Facebook at NU Institute for Global Health or by email at globalhealthinstitute@northwestern.edu. Starting with the CDC's most recent COVID statistics for the United States. Average new hospitalizations per day, 2,875. 2023, same week, 3,775. Average COVID deaths per day, 161. Same week in 2023, 335. New 2023 COVID vaccine uptake for adults, 22.3%, for adults 65 plus, 41.8%, and among children, 13.1%. Dr. Murphy, your reactions to those numbers?
Yeah, not too much change in the last couple of weeks. It's not as bad as it was, so it's the numbers are just slightly improving, and we would expect that, and we would expect further improvement over the next month. So at the end of March, beginning of April, sort of is the end of the respiratory infection season in the Northern Hemisphere, and we're on target to end that those outbreaks. And about half of those outbreaks are now caused by COVID, flu, or RSV, respiratory syncytial virus, and half are caused by other minor viruses that usually don't have very serious consequences. So remember, if you do feel ill, a respiratory illness, you have a 50% chance approximately of having something that might have a treatment. You should consider getting diagnosed and treated.
Absolutely. And kicking off with our first story this week, there have been several reports from different parts of the US with crop-ups of measles cases. Can you tell us a little bit about where they are and how many there have been?
Yeah, so measles was almost eradicated in the United States in 2000. What has happened is we've seen these outbreaks pop up around the United States and the world, mostly in people who are not vaccinated. Measles is highly, highly contagious. Measles can kill a person. They can get encephalitis. They can die. I mean, it's not common, but anything can happen. You have to be careful, but that's why the vaccine is recommended. So anyhow, in 2024, this year, only 2 months into it, there's been 35 cases. First case in Michigan, first case in Indiana, none in Illinois, by the way. And Florida has 7 or 8 cases. So Florida is kind of the poster child for, if you want to have a pandemic, come on down to Florida, because they have basically stopped believing in infections and public health control to keep the infections down. So it's going to be interesting to see what happens down there, how bad it's actually going to get. But remember, measles, very preventable with a simple vaccine. And if you get that vaccine, it works for the rest of your life, basically.
Mm-hmm. And switching to COVID, but sticking on the topic of public health decisions and how we as a population react to them, there's been a lot going on in the media and in the scientific community lately about COVID being fluified. Can you explain a little bit about what that means, what people are saying, and then the argument being presented?
Well, what is happening among public health officials worldwide, actually, it's not just the United States, is should we be just lumping all these severe respiratory conditions like RSV, flu, COVID in one basket? Or should we be trying to differentiate between them? And on the one hand, if you treat them all the same, the message might be more clear to larger numbers of people. On the other hand, these diseases, these infections are very different. COVID is much worse than the flu. For instance, in 2023, COVID caused 900,000 hospital admissions. In the last 10 years, the worst case for flu was 700,000. So 200,000 more people get hospitalized with COVID. And that's based on the worst year in the last 10 years. As far as deaths are concerned, COVID killed 75,000 people in 2023. I mean, it's a far cry from the 1.1 million that died in the first 2 years. But the worst flu death rate was 52,000. And during the COVID peaks early on, 2020, 21, there was almost no flu. It outcompeted flu completely. So why is that important? Well, it's important because COVID is a worse disease. So should we be doing something about it? Should we be doing more about flu? Respiratory syncytial virus, we're just starting with the vaccine. There's no treatment yet, but that may come. So that is the whole issue. And we, as our public health approach to these things is really inadequate. It varies by state or territory, sometimes even by city. And, every time you put a hurdle in front of somebody getting a diagnosis, somebody getting an effective treatment, people just drop off the system. It's so unfortunate that these things are being just accepted. Like, we're just going to have to just live with this, and we're not going to do very much about it. That's the way it is. But, the individuals are going to have to take it upon themselves. If you want to get protected, keep up to date with your vaccines. If you're at high risk, get another COVID booster in the spring. And, knowledge can be helpful. So if you get sick, get diagnosed. If you have to go to a clinic, go to a clinic. In the next respiratory season, so in next December of this year, 2024, it's very likely that when you go buy a COVID test, it's going to have respiratory syncytial virus and flu, all in the same test. That's going to help a lot. And, it's a step in the right direction, but still, if you have to buy it and you don't have the money or you don't want to spend the money, it's not going to do anybody any good. So we'll see what happens.
Mm-hmm. Sticking with COVID, we had some very helpful viewer submitted questions this week. So thank you. That linked to some very, very important research that just came out regarding the mRNA vaccines and their efficacy over time. Can you first talk a little bit about hybrid immunity and rebounding and what these findings on the vaccines really inform about that?
So what we're talking about here is the vaccine response by measuring the antibody that the person has in their blood after a period of time. So this is a study in 501 healthcare workers in New York City who were followed over time with repeated blood tests from April 2020 to March 2023, so a year ago. And they found the average age, they're healthcare workers, so the average age is 41, so younger adults, all right? They found that, we all have been saying, the titers of the antibodies go down and whatsoever. And however, it looked like in this group of people, so they're typically, they're not like sick, and, they're not living in a nursing home. They don't have necessarily any underlying severe diseases. But in this group anyway, the steady state of the antibody titer went down and sort of leveled off at 7 to 9 months. It didn't keep dropping down. So in this healthier population, it looks like that immunity lasts for many years. So that's great news, really good news. But keep in mind, it's for a healthy working person. Now, hybrid immunity, you mentioned, the antibody, interestingly, the antibody titers were much higher if a person not only had the first two shots of two vaccine doses, but if they also had COVID. So they had the real infection, plus they had the vaccine. That combination actually gave them a better response.
And do the new variants that are circulating around change any big factors about that situation? Or if you had the recent 2023 vaccine and recently had COVID, excuse me, could you expect that same hybrid immunity?
Oh yeah, no, it'll work. And the newest vaccine is designed specifically for the Omicron family, and that's what's circulating.
Yes. And you mentioned this briefly in this last story, but a big announcement this week from the CDC was that they would be recommending a second booster shot of the 2023 COVID vaccine to people over the age of 65 in the springtime. Can you break down their decision making?
Yeah, so this is the advisory committee to the CDC about vaccines, and they took a pretty strong stand saying you should get this booster if you're in this high-risk group. So not for everybody, but for the high-risk group. That's good because you will, as I just mentioned, COVID is a nasty disease and a lot of people die from it still. And the higher risk you are, the more your risk of having a bad outcome. So get that booster if you're in the high risk group, and you don't have to get it like today. You can wait till the spring, get it sometime during the spring, and then you'll be prepared for the next respiratory season. Now, remember, the other thing about COVID is that it doesn't just come around once a year like flu and RSV. Remember, we had those big outbreaks in August, and you can have outbreaks any time of the year. So it's a little bit different.
Absolutely. And another COVID subject that we have had a lot of sustained interest in is long COVID. There's a study out of Ireland that was just published with some pretty groundbreaking results regarding a mechanism for long COVID brain fog. Can you please break that down for us?
Yeah, so, brain fog is very common in people with long COVID. So how many people get long COVID? Somewhere around 7%, but the numbers are all over the place. It depends how you count. Anyway, we know it's real. And what this study shows is exactly how real it is. They found that in the people who had brain fog, cloudy thinking, 3-6 months after they had COVID, they have an elevated protein in their blood called S100 beta, and that is associated with a leakage of the blood-brain barrier, all right? So that something's wrong between the brain and the blood. And they found that elevated protein, and then they did MRI scans, magnetic resonance imaging scans, very good imaging of the brain, radiology finding, and they found the same thing. I mean, they found the physical kind of leakage, and it just says all this points to is that brain fog is very real, and it's what they say, big word here, pathophysiologic. It's causing disease, and we can actually see the disease and what's happening. So understanding that it's happening and how it's happening is the first thing we can do to perhaps build better treatments.
Absolutely. Yes. And we will, of course, continue to look into those findings and anything similar. We know we have a lot of interest there. But moving on to RSV, specifically in infants, there's been a lot of talk about how hard it was to get a hold of the infant immunization for RSV. Despite that, there were some pretty great numbers released from the CDC this week. Can you tell us about it?
Yeah, so let's just talk a little bit about RSV in young kids, all right? The RSV accounts leads to 2.1 million outpatient visits per year in kids under 5, 58 to 80,000 hospitalizations. That's a huge number of hospitalizations, right? And 1 to 300 deaths, which is of course horrible, and you want to avoid them. So that's the background. So the treatment is a monoclonal antibody that requires 1 dose. It's recommended for kids under, I think, 8 months, but up to a year in some cases. And it's actually the antibody against RSV. And when you do that, the rate of RSV severe infections, hospitalizations, and death plummets. So everybody wants to get it. So they underestimated how many people actually wanted that thing. And it was, they're trying to ramp up production and whatever. But at the end of the day, 50% of people were able to get a hold of it for their kids. That's amazing. We got up to 50% and didn't even have enough of the stuff to go around. Now, there's an alternative way to treat this. If you can't get a hold of that, a mother in her second trimester can get the regular RSV vaccine, which is now approved for people over 60. I just had it myself several weeks ago, no problem. Anyway, if those women take it in the second trimester, they make an antibody that's passed on to their baby at birth, to the fetus, and then the baby has it. And that's just as good as taking the monoclonal antibody. They're getting the antibody that the mother made. So that's another way to do this, found to be very safe. And you improve outcomes in these young, fragile kids. Kids don't like RSV. It's causes a lot of problems.
Absolutely. And time will tell when we get the actual data of the effect or whether or not this drug had an effect on changing those big numbers that we've seen from RSV in previous years. Of course, as production gets better, the numbers hopefully will go down as more and more kids can get these really potentially life-saving drugs.
I mean, can you imagine if we could just almost eliminate 80,000 hospitalizations per year and 300 deaths? I mean, that would just be remarkable.
Absolutely, particularly with the cost that has just on the general family and, just on the system. And it would be huge. Just totally great. But moving on to our final story of the year, something not as great, norovirus, something we haven't talked about a lot, has been on the uptick in the Northeast US and has been seen popping up globally. Can you talk to us a little bit about that?
Yeah, it's a highly contagious form of diarrhea, causes diarrhea. It can be very disabling. Very few people die from norovirus. It's not a life-threatening thing, but it certainly can be very uncomfortable. It's just popping up. It's in the Northeast. It's kind of big in the South right now. And then, whether this is related or not, but there was a cruise ship. Often this happens on cruise ships, by the way. On a cruise ship in the Indian Ocean, the cruise ship was not allowed to dock on the island of Mauritius. All right. And the reason was because they had this outbreak of some kind of diarrhea. They don't know what it is yet. Whether it's norovirus or not, it could just be some other kind of virus that causes, or other kind of infection that causes diarrhea. But anyhow, I mean, it just is interesting that those two stories pop up at the same time. We don't know if they're related, but they could be. But it's just a word. If you've got all of a sudden some weird, terrible diarrhea, it may be this virus, highly contagious. So people in the family could also get it. So you have to be careful.
Absolutely. Just generally make sure you're washing your hands and stay clean and
Right.
stay healthy.
Common sense works every time.
On that note, Dr. Murphy, thank you very much for your time and expertise this week, answering viewer-submitted questions, breaking down the headlines, and U.S. COVID statistics. Much appreciated.
Yeah, and I'm signing off from St. Bartholomew's Island in the Caribbean, which is having kind of a little dengue outbreak here. We had talked about dengue the last couple of weeks, but the cases of dengue actually have started to drop here, but it's a great place.
Awesome. Well, that is great news. Stay safe to you and everyone out there. Thank you again for joining us this week. If you have any questions, please submit them down below or at any of our social medias in the description. Have a great weekend.
Have a good time. Good weekend.